and the international communist conspiracy to sap and impurify all of our precious bodily fluids.
We are here with Dr. Joel Topf, a clinical nephrologist in Detroit. He is a partner and medical director at St Clair Nephrology and an assistant professor at Oakland University William Beaumont School of Medicine. He's the co-creator of NephMadness and NephJC, and he also hosts multiple podcasts. He blogs at pbfluids.com and tweets at KidneyBoy. Joel, welcome to the External Medicine Podcast.
That's awesome. Thanks for the invitation, and actually sweet name. I like that, External Medicine. Well done.
Before we get started, do you have any financial disclosures?
I have a number of them. Okay, we can just go through them. So as a nephrologist, one of the opportunities that you can have, especially in private practice, is you can be an owner of a dialysis unit. So I have small stakes in numerous dialysis units. My practice runs a vascular access center. So this is another thing where I don't do vascular access, but my practice, which I'm an owner of, makes money doing vascular access procedures, which is opening up dialysis access. In 2018, which is a deep cut, I know, Takeda Pharmacy Oncology sponsored a trip to Mount Everest Base Camp, and I got the opportunity to go on that. It was absolutely amazing experience. There were a number of multiple myeloma patients who were on that trip. And so to participate in that kind of thing was amazing. And then recently I've been invited to be on a number of advisory boards. And these are private confidential meetings where you meet with the scientists at these pharmaceutical companies, and they talk about their drug and they talk about their research, and they look for advice. And some of the advice is marketing. Is this a good message? Some of the advice is what type of research should we be doing next? What people should we be experimenting on with this drug? Is this going to be an effective drug there? And I've done this for a company called Cara Therapeutics, a company called AstraZeneca. Everybody's heard of that one. Bayer, Tricida, and I think that's it. Oh, and then part of my work in social media, there's an organization called NephJC. It's primarily known for putting on Twitter journal clubs, but we also run an internship, and we sponsor a lot of educational initiatives, and I am the president of that. That is a 503c organization. We don't have NephJC has industry and academic supporters, but specifically by our bylaws does not allow any pharmaceutical support, and all the board members, of which I am one, are prohibited by the bylaws from receiving any money from NephJC itself. The organization truly is a nonprofit.
All right, great. So
conflicts all over the place. Let's get to the answer.
All right, well, we got that out of the way. So recently you've been talking a lot about contrast-associated, contrast-induced nephropathy. We want to dive into that subject with you. But before we get there, we want to just talk about acute kidney injury. So if you could define AKI for us.
Yeah. So a classic definition of acute kidney injury is an acute and significant drop in kidney function. And this was it's a textbook definition from 50 years ago. And people say, oh yeah, this patient has acute kidney injury, or we used to call it acute renal failure, but same thing. But this was it's a good definition. It makes sense. It's what we're talking about. Oh yeah, the kidney was working and now it's not working. But when you wanted to do a study and you wanted to study it, it became difficult to operationalize such a generic description. And what actually happened, since there was nobody who did operationalize it, is every researcher came up with their own definition. And in the early 2000s, at the turn of the century, there were probably 30 or 40 different definitions, and they ran from super sensitive. And so if you looked in the cardiac bypass surgery literature, they'd be looking at a tiny 0.3 milligram per deciliter increases in creatinine and calling that acute kidney injury. And then if you looked at a lot of researchers that looked at like cost of care, they were looking at billing. And the only way they could get reliable billing is like, well, if anybody got dialysis for acute kidney, got dialysis, it wasn't on dialysis to begin with, we're going to call that acute kidney injury. And the difference between those forms of acute kidney injury are completely, those people couldn't even talk to each other, right? One is almost a meaningless change in creatinine, and the other one is a life-changing event like dialysis. But they both had their advantages, and they both really came out of a situation where researchers were really looking at the tools that they had available, right? If you're looking at billing receipts, dialysis makes a lot of sense. And it's there's other advantages to it. It's certainly a patient-oriented outcome. Nobody would dispute that. While that modest increase in creatinine, maybe it's not so patient-oriented. A lot of patients would be like, what do you mean I have acute kidney injury? I'm fine, right? Because a week later, their creatinine would be back to normal. But those researchers at the same time could say, well, actually, when we look at all the people that get bypass surgery, the people that have these tiny increases in creatinine actually have more complications and more poorer hospital outcomes. And so both of these definitions in their respective areas made sense. And what we went through really in the 2010s was a lot of renting of fabric as we tried to figure out, establish consensus definitions. And so the first one that came out was called the RIFLE criteria. And the RIFLE was an acronym for risk, injury, failure, which were increasing levels of either oliguria or increasing creatinines, and then two outcomes, either loss of function or end-stage renal disease, which were durations of dialysis that had to happen. And this was actually, it's amazing because it was kind of the first attempt at kind of getting a consensus definition of acute kidney injury. And if you look at what we use today, which are called the KDIGO guidelines. So the KDIGO is a big international guideline organization that we've created for nephrology. And among the things they've created is consensus definitions of acute kidney injury that have been widely adopted. And you can, if you read the KDIGO guidelines and then you flip back 14 or 15 years to the RIFLE guidelines, you're like, oh yeah, they're largely the same. Like it really, those RIFLE guys got it right. That was an organization called the Acute Dialysis Quality Initiative, ADQI. I don't know if they're still in business now, but KDIGO really has largely adapted them. There was a group in between called ACAN. And so unfortunately, or the reality is the definition is largely based on changes in urine output and changes in creatinine. And so KDIGO says a bump in creatinine of 0.3 up to, or increases of creatinine greater than 0.3 is going to be acute kidney injury. That's what it takes. That's the threshold. And then they divide it into three different stages, 1, 2, and 3. And there's been a number of studies that show, you know what, if you get 2, it's worse than 1. And if you get 3, it's worse than 2. And so those are, we call that a validity, they're valid, right? It's not just an increase in creatinine. That increase in creatinine actually translates into poor patient outcomes. And you can measure it any way you can measure it in length of stay in the ICU, number of patients that are intubated, or number of patients who receive dialysis, or hospital mortality. Any which way you cover it, 3 is worse than 2, which is worse than 1. And those are largely, 1 is a creatinine bump all the way up to a doubling of serum creatinine. Stage 2 is a doubling to a trebling of the serum creatinine, and stage 3 is greater than a trebling of serum creatinine. And there are associated changes in oliguria also, but most people don't use those changes in oliguria when you look at a lot of the data on it.
And how good of a marker would you say that a rise? So in the hospital, you see a patient, their serum creatinine is one thing one day, and then the next day it goes up. Let's say it goes a 50% increase. How good a marker is that of actual kidney injury?
Well, creatinine is not a great marker for acute kidney injury, except for, what do they say about democracy? It's the worst form of government, except for all the other ones. And creatinine is kind of the same way. It's the worst way to measure kidney function, except for all the other ones. Like, the reason we use it is because it's, first of all, it's super available. People are familiar with it. There's a lot of momentum behind that. But there's also problems with it. So it's a lagging indicator. So you can get an injury on day 1, and you may not see that bump in creatinine for 72 hours. And in that 72 hours, you may be giving them ketorolac, and you may be giving them contrast, and you may be giving them aminoglycosides. You could be doing all sorts of insults to the kidney that you may not choose to do had you known that the patient had suffered some injury. Okay. And so that's a lagging indicator. And then there's a ton of information about problems with race adjustments that have been used for creatinine to create EGFR, which makes it problematic. And where that and a lot of that origin of that, we know that creatinine is related to muscle mass. We know that the muscle mass argument doesn't hold true for Black people versus white people, at least in the United States, when we've looked at that. The reason that Black people have higher creatinines is not related to muscle mass. That was examined and it did not pan out when you adjusted it for BMI and muscle mass. It didn't balance those numbers out like we would expect to. So there's the muscle mass issues problem, right? When we look at the creatinine, if the patient has an amputation, that's going to result in a lower creatinine. Well, that patient's probably, their creatinine is going to rise slower also, right? They have less muscle mass to generate the creatinine. That's going to make this marker of acute kidney injury less accurate for those patients, in the same way that we found that pulse oximeters are not as accurate for people that are Black, people with dark skin, right? And that's not acceptable. We need to be able to assess people's injury independent of the color of their skin, or whether they've had amputations, or whether they're just have high muscle mass or low muscle mass. We need better markers. And we are making some progress now. There is a new licensed test called the NephroCheck, which is essentially, it's two different markers of cell growth, cell repair, that increase, they're cell signalers that increase in times of stress or injury to the kidney. And you multiply them together, and this gives you a pretty good hint of acute kidney injury to come. And the study, the test will either be positive or negative, but it doesn't give just a positive or negative. It actually also gives you a number, and the higher the number, the more likely it is. Even if it's positive, a higher positive is more significant than a less high positive one. And this NephroCheck is interesting. It is definitely part of the future. And this is part of the answer to the question, why are we still using creatinine? Well, we're working our way to getting better assessments of this. And NephroCheck is part of that solution. There will probably be other future tests that are also helpful in this circumstance. But the question that you asked is, can a bump in the creatinine, does it actually mean injury to the kidney? And no, I mean, sometimes it doesn't, right? Sometimes you get a bump in the creatinine and it's just a hemodynamic change, right? We see that all the time. Everybody has seen the patient comes in with a high creatinine and you give them saline overnight and the next day the creatinine's better. Oh, we're not allowed to say saline anymore. Lactate erythropoiesis, balanced solutions. Yeah, so things are getting better. We're like all of medicine, nephrology is moving forward.
So you have a patient, they have a bump in their creatinine that qualifies as an AKI. What is your workup that you do for a patient with an AKI in terms of laboratory tests, imaging findings, et cetera, in order to figure out like what's actually going on?
Yeah. So what I like is, I think, whether you say you're a Bayesian or not, like that's just the way we approach things. Is we kind of think, well, what are the likely things when you have an increase in creatinine? And I think one of the most helpful ways to differentiate, to kind of set up your pre-test probability, is just what area of the hospital are you in? Is this patient in the ER? Are they rolling into the ER, fresh patient with an elevated creatinine? Those patients, I think, are largely easy because, 70 to 80% of them are going to be pre-renal azotemia. Another 10 to 20% of them, depending on the patient population, are going to be obstruction. And so, what I like to say is that a bag of saline and a Foley catheter takes care of 90% of AKI, right? And these are patients that are rolling into the ER, community-acquired AKI. And then the 10% of them are going to be what's left, and what is left, right? And most of it is going to be acute tubular necrosis, okay? And what's the therapy for acute tubular necrosis? There is no therapy for acute tubular necrosis. Just wait it out, okay? And you give supportive care. You don't give them any aminoglycosides. You don't let them get hypotensive. We take away the ACE inhibitors. We don't know if that helps, but we all do it, right? It'd be interesting. Boy, for something that we all do, it'd be great to see a randomized controlled trial to see if that makes a difference. I am super interested in that. And that's probably 80% of those. So now you're down to the last 2%. And what are those patients going to be? And there's going to be acute glomerulonephritis, which is the frightening one. There could be multiple myeloma causing, kidney to have acute kidney injury, hypercalcemia. It can be acute interstitial nephritis, an allergic reaction, usually drug-induced, localized, and not necessarily localized, but largely affecting the kidney. And so you want to differentiate those, right? Because while the treatment for acute tubular necrosis is do nothing and be supportive, the treatment for acute interstitial nephritis, some of those patients benefit from steroids. And it's something that you want to investigate. I got a patient right now who's sitting on the edge of dialysis, who has biopsy-proven acute interstitial nephritis. And knowing that's the diagnosis makes a huge difference, right? And, and so getting that biopsy is important. And right, or if so you want to be able to pick up the acute glomerular nephritis, right? Because that's another patient. If they have crescents, you're going to need to put them on cyclophosphamide and give them a high dose of pulse steroids. That's another patient you don't sit on. So once you've given you've ruled out an obstruction or put the Foley in, or done the POCUS test to look for a big bladder or a hydronephrosis, and you've given them saline and they're not responding there, you want to try to lock in your diagnosis of ATN. And the best test there is going to be a urinalysis with spin the urine and take a look under the microscope. And, clearly not something that we expect ER doctors to do. It's not something we expect interns to do. That's my job. Right. So once you fix the 90% and you got the other 10%, most of those are going to be acute tubular necrosis. Get a UA. And if you see blood and protein there, you should probably be like, ooh, this is concerning. We ought to get a nephrologist to take a look at that.
So this question sort of related to the categorizing of AKI into pre-renal, renal, and post-renal. For the possible pre-renal patient, there are lots of different ways that people say that you should evaluate volume status. Some people say you can do it on a physical exam, the history. Other people say you need urine-lytes or doing an ultrasound of the IVC. Where do you sort of come down on that controversy of evaluating volume status?
I mean, it's one of the core skills of being an internist. Right, is you need to be able to know, take a look. Every single person on an internal medicine service in the hospital is either on diuretics or IV fluids, right? Everybody, okay? That means that every single person that gets admitted, the doctor who's in charge or a consultant is assessing volume status. We all do it, and we do it all the time, and we all have our ways to do it. And and not one single test that I'm aware of is perfect. They're all relatively lousy, and we use a mixed group of history and physical and things we learn in medical school, and we all get relatively good at it, and there's going to be some variation. I'm not a POCUS expert, so I'm not great at doing that. Though I'll tell you, I do find the collapsibility of the IVC to be helpful, and I like it when I have a resident that does that. I definitely take a careful look at that. Orthostatics are crap. Whatever you were told about orthostatics, those do not work. It's just too many patients have autonomic dysfunction. There's too many patients that are longtime diabetics that they're gonna have a drop in blood pressure not related to the volume, and it's just not reliable. And the mucous membranes, if they're a mouth bracer, they're not great. Axillary sweat is supposed to be quite good. And so you get that moist axilla. That's probably not somebody who's dry. And then, as a nephrologist, you want me to talk about fractional excretion of sodium and the BUN to creatinine ratio. And, when these tests are studied in isolation, when someone says, we're going to blind you to all the other information of the patient, and we're just going to give you the FeNa, they typically don't work great. Okay. But that's kind of a silly way to do it, right? It's like, we're not going to give you any history. We're just going to give you a stethoscope and we want you to diagnose pneumonia. And people are like, I can't do that. Right. It's part of a global, the auscultation is part of the global assessment. I'm going to want a chest x-ray. I'm going to want to talk to the patient. I want to see if they're coughing, right? I'm going to do all of that. And I'm going to make the diagnosis of pneumonia at that point. And if someone showed you a study that the stethoscope alone with no other information was lousy at pneumonia, it doesn't mean you wouldn't say, okay, well, that's compelling data. I'm going to throw away the stethoscope. You'd be like, no, that's just not how I use that tool. I use it as part of my global assessment. And I would argue that much of the data on fractional excretion of sodium is analogous to that. It's like, we didn't look at anything else. We just looked at the fractional excretion of sodium and we saw how well it performed for this diagnosis of pre-renal azotemia. And it didn't perform very well. And I'm like, yeah, I'm not surprised, right? Or it performed extremely well. And I'm like, well, that's also overstating it, because there was a meta-analysis just published last month in one of our high-profile society journals, the Clinical Journal of the American Society of Nephrology. We call it CJASN. I couldn't even remember what the real name was. I call it CJASN all the time. That's the Clinical Journal of the American Society of Nephrology. And it was a big systematic review and and meta-analysis on fractional excretion of sodium. And it looked like it had about a 90% sensitivity or something like that. And that's better than I expected. Because in my mind, it never worked nearly as well. And I think the reason is that for most of the patients, I don't even use it, right? Like I go in, the patient's been vomiting for days and they come in and they're dry as a bone. And it's like, everybody and their mother knows that they're dry. Who's ordering a fractional excretion of sodium in that patient, right? And no one needs a fractional excretion of sodium there. And on the other hand, you have patients that are just the opposite. They're, clearly fluid overload. They got edema for days, and you're not going to do the fractional excretion of sodium there. It's not going to, that this patient is not dry. And so I don't care how it performs in those patients. What I can care about is how well it performs in the marginal patients, the patients where I go in and I'm like, this one's tough. I'm not sure what I should do. And that's not rare. That happens a lot, right? I mean, when you go in and see patients, sometimes it's obvious and sometimes it's not. And when it's not, that's when you'd want the FeNa to work well. And in my experience, it doesn't work great. That it's part of that global assessment, but it's not alone. And fill in Phe-urea and fill in BUN to creatinine ratio and urine sodium and osmolality ratios and every other trick that someone's trying to do this is, in the end, they're okay. They may help you. They may shade your decision. They're part of that global assessment. Sure. If this is something that you like doing and you're comfortable doing it. But I think testing them alone is not a great way to test them. No, I don't think that's realistic to expect one test to be that good.
Yeah, these questions we came up with specifically in the context of being in the ICU, where I've had attendings leave service, a new one comes on, and the old one was like, this patient is totally volume overloaded. We need to diurese this patient. The next attending comes on and has the exact opposite. We need to give this patient fluids. So in the context of really, we don't know if this patient's third spacing, they've been in the ICU for 3 weeks. They've gone through successive rounds of attendings with their own opinions of volume status. I guess, I was really curious in that context where the history, isn't really going to tell you as much in that situation as it would have in, say, a patient in the ED.
Yeah. I mean, again, everybody has their own opinion on this, and sometimes they're right and sometimes they're wrong. And I think it's also important to reframe that question, because what they really want to know is this patient volume responsive? It's not so much whether they're dry or wet. It's, if I give these patients IV fluids, is their blood pressure going to come up? And I'm a big fan of, if that's the question, give the IV fluids. Find out the answer directly. I mean, well, there are patients where that's, you have marginal oxidation, you need to be careful. But the FeNa data, if you take a look at the fractional excretion of sodium and you look at the fractional excretion of urea, right? So you understand what you do the test, and then you need to know what the truth was, right? In order to evaluate whether that test was positive or negative, whether the test was successful or a failure. And so what's the gold standard in that situation, right? You can only do that. You can only do that analysis if you have a gold standard. And the gold standard is the patient gets the fluid and they see if the patient responds the next day. And I'm like, so you're telling me I need to order urine sodium, urine creatinine, urine urea, serum creatinine, and serum sodium, so I can do this cool math. And I think the math is super cool. So you can then, so I can get an answer that may be anywhere from 70 to 90% sensitive and specific. To find out what would happen if I just gave the patient a bag of saline, I'm just going to give the patient a bag of saline and get to the answer directly. The gold standard is sitting right out there, super easy. It's not like you have to do a biopsy. I'm not doing a brain biopsy here, right? I'm not doing something, yes, it may be dangerous, right? If you have patients in heart failure, but quite honestly, if the patient's in decompensated heart failure, I'm not going to give them fluid anyways, regardless of what the FeNa shows me. So I think that these tests have a role, but to try to don't over-index on them. Don't put too much weight on them. They are not super accurate. They're not super reliable. There's a million exceptions to them. And, if you're an expert in this topic, they will help add to your global assessment. And if you don't know what you're doing, they're going to make the wrong decision. I know I used the fractional excretion of sodium when I was an intern, and I'm sure I harmed patients with my use of it. Like, I just wasn't very knowledgeable, and I blindly followed it because it seemed complex, and I had to do a lot of stuff to get to this answer. So it must be highly valuable. And I don't think, and that's not true. Even though it was really hard to get and took me a lot of stuff, and I had to do math. That's a long time ago. There's no web, there's no med calc, right? I had to push the pencil and paper myself, and had to look up the formula somewhere in some book that I had in my pocket. Like I worked really hard to get the answer, so it must be valuable. Is not true.
So let's talk about contrast-induced, contrast-associated nephropathy. So in 2006, the New England Journal of Medicine had a review article about contrast-induced nephropathy. And then 13 years later, in 2019, they had one about contrast-associated nephropathy. Can you talk us through what happened during that period? Why did the label change?
Yeah, right. I mean, I think it's so hard to learn all the stuff in medicine. And it's even harder when the stuff you learn turns out not to be true, because things are always changing. And I think that, technology has advanced dramatically since the 1990s. And I think that 2004 article really or 2006 article is really a reflection of a lot of the data that we collected in the 1990s. We didn't get low osmolar contrast. I mean, I think the study in the New England Journal of Medicine showing low osmolar contrast agents were safer than high osmolar contrast agents. That's early 2000s, 2001, 2002, just a couple of years before that article comes out. And so the agents that we were using were much more toxic than what we're using today. And the doses that we were using were much larger than we're using today, just because the technology in our CT scanners has gotten better. They're much more sensitive, and they need less of the contrast agents to get good pictures. And so, and there's been this whole safety culture around this that has resulted in, the recognition that, hey, contrast, the kidneys are sensitive to this contrast. We ought to be careful with it. And that resulted in lots of things happening. And part of it was we got safer contrast agents. And another one, we got better CT machines, so we don't need to use as much contrast. Another one is we're going to use better patient selection. And all this went into making contrast safer. And as it made it safer and safer, the signal that contrast caused AKI got fainter and fainter and fainter. And it took, it's funny, there were the first attempts to kind of look at this were just, there's never been a randomized controlled trial where you randomize patients to contrast or no contrast. Like, you can't even do that, right? I mean, largely ethically infeasible. And once it became feasible, nobody wanted to do that. Nobody wanted to enroll their patients. But so what they did is they did uncontrolled trials where you would have patients that would be in the ER and they would get a CT scan, and someone would get contrast and some would not. And then we would just look at the rates of AKI after that. And it seems like a reasonable study design, but if you think about it for more than a couple of minutes, you're like, wait, this is going to be problematic, right? The people that don't get contrast for a reason, right? And the patient that rolls into the ER with 4 nephrons connected by scar tissue is the patient who's not going to get contrast. Nobody's going to give that patient contrast, but that patient is a walking AKI waiting to happen, right? And so all of a sudden you load up the arm of that study with patients that have super fragile kidneys. And no surprise, the people that didn't get contrast had a higher rate of AKI, right? And then the other thing about that control group, right? The control group, if they're in your control group, they have to get a CT scan, and they have to have a creatinine both before the CT scan and after the CT scan. Well, not a lot of patients people that you bring into the hospital, you start getting creatinines every day on, are patients that you're worried about their kidneys. So it's another way to subtly make the control group way sicker than your typical patient. And so this became, like I said, these early attempts at these controlled trials resulted in no signal for contrast nephropathy. And I don't think they convinced anybody, right? Because people are like, that's a terrible study design. And so like the next evolution is propensity scoring, which is a cool statistical technique where like, well, Joel, you just described a patient that you would never give contrast to, got 4 nephrons connected to this with scar tissue. They're 80 years old and they've got diabetes and multiple myeloma. Of course, you're not going to give contrast to that patient. But those are all measurable. We can give them points for multiple myeloma and diabetes and age and GFR and heart failure and anything else. And so what we do is before they get this, it's a retrospective study, but you can go through and you can say, every single patient in this study, we're going to give them a likelihood of developing contrast nephropathy. And once we have that likelihood number, that score, we're going to make sure our groups are balanced. The people who get contrast look a lot like the people who don't get contrast in terms of their propensity to develop AKI. And when you do this, you've kind of eliminated a lot of this problem. And there's still no signal that people who get contrast have AKI. And you're like, oh, well, that maybe there's, and this is done over and over again. There's meta-analysis of these propensity trials. I mean, it's tens of thousands of patients, and we're not seeing any signal that contrast is causing AKI. And if you look at, I mean, these are all in the teens, the 20 teens, and these are coming out. This is not early, this 2012, 2014 when this starts coming out. I think the first propensity trial, I want to say it was 2016. And so that, no signal there. And then there's a really interesting trial that used a discontinuity analysis. And, this is looking at patients that come into the ER, they're suspected to have a PE. And they get a D-dimer. And in Canada, D-dimer greater than 500 is a positive. And so if you kind of track the likelihood of getting a CT angiogram with contrast, by D-dimer, it's real low until they get to 500, until there's a little H next to the D-dimer, and all of a sudden it shoots up. Okay, so it's like 5% of people get a CT angiogram with a D-dimer of 499, and 35% of people get contrast-associated, a CT angiogram with a D-dimer of 501. Right, just all it takes is it to cross over into the high, and there's this. So that what you have is this discontinuity. This nice curve, nice gradual curve until you get to 500, and then it shoots up. And what that allows you to do with that discontinuity analysis is say, well, the people with 499 probably, other than the fact that they get contrast, look a lot like the number of the people that had a 501 D-dimer. And sure enough, when you look at their diabetes rate, there's no difference on either side of that line. You look at their age, there's no difference on either side of that line. You look at their eGFR, there is no difference on either side of that line. And so the question is, well, do they have differences in long-term outcomes? Do they have a decreased GFR long-term as if they took a kidney hit from that contrast? And there's no discontinuity across that line in terms of their long-term eGFR outcomes. And so what I'm just trying to say is that we use the fanciest statistics we could come up with, and we can't see a signal in contemporary studies that this contrast is harmful. And I think the answer is because it's not harmful anymore, right? Certainly in GFRs greater than 30, there's just no signal that this stuff is harmful. Now, at low GFRs, that probably is different. CKD stage 4, stage 5, that there are some meta-analysis of those propensity score trials that say, hey, this is different. These patients are more fragile. I'm not entirely convinced, but it's worth having some caution there. But the vast majority of patients, that's not the case. And I'll tell you, what I'm saying is not, it may sound like I'm a bomb thrower, I'm a radical, but this is quite in line with the National Kidney Foundation came out with a statement in 2020. The American College of Radiology came out with a statement in 2020 saying, hey, CKD stage 3, which is GFRs 30 or higher, or patients with a predisposition to heart failure, stop giving them saline, stop worrying about this, go ahead and give them contrast. They're fine. And now GFRs less than 30, your stage 4s and your stage 5s, you need to think about it. But my position is, we don't give contrast for no reason, right? These patients the most dangerous thing to be in the hospital is a patient without a diagnosis, right? You're sitting there, you're just getting tests, and oftentimes a contrasted study is what gives you the diagnosis, which answers the question, allows patients to move along. And so I'm a big fan of getting a diagnosis. And if what it takes to get that diagnosis is contrasted CT, let's get the contrasted CT. If by chance they run into trouble, we'll figure it out.
Just to go back really quickly, so we defined what an AKI is, but we didn't really exactly define what the contrast-associated or contrast-induced AKI is. Is that just a time period between getting contrast and developing it? Or how do we know, like, definitionally, what is a contrast-associated AKI?
You're feeding me softballs, right? So the definition for contrast-associated nephropathy is a change in serum creatinine of 0.5 milligrams per deciliter or 25% within 48 hours to 5 days after contrast. Okay, so if they bump their creatinine after getting contrast, I don't care if they were on aminoglycosides, if they had hypotension, if they were septic, we're calling all of them contrast-associated nephropathy. And the definition from contrast-induced nephropathy to contrast-associated nephropathy or contrast-associated AKI, which is what some people are using, all of those are different names for the exact same thing. They never changed the definition based on those. They were just renaming the same old entity, which is a terrible definition, right? If you take a look at other diseases, like hepatorenal syndrome is the one I love to use. Hepatorenal syndrome, if you're familiar with it, has very specific diagnostic criteria put together by the International Club of Ascites, which is like the greatest name for a disease organization. It's a swinging club of ascites. They have all these exclusions, right? So they require cirrhosis and ascites because that's the clinical scenario. That's great. And that's exactly what we have with contrast nephropathy. We have the right clinical scenario within 24 to 48 hours of a contrast administration. 2, they require development of AKI. They have their own definition of AKI. It's not so different from KDIGO. Same thing here, in contrast nephropathy, 0.5 milligram or 25%, same thing, definition of AKI. And then 3rd, hepatorenal syndrome, we don't want to have patients with pre-renal azotemia. So we want you to stop all the diuretics. And we want you to give them an albumin infusion. In fact, we're going to ask for we're going to give you 1 gram of albumin per kilogram. They specifically say how much fluid they want you to give the patient to rule out pre-renal because they don't want to contaminate their pool of hepatorenal syndrome with people with other causes of AKI. The contrast people don't do any of that, right? They take anybody with AKI after contrast. Right. Hepatorenal syndrome says, if you're on nephrotoxins or you have sepsis or you're hypotensive, we don't want, I'm not sure if there's hypotension because there's a lot of hypotension in hepatorenal, but no nephrotoxins and no sepsis. We don't want you in the pool. And that's, again, they're removing things that may be causing ATN from that pool of hepatorenal syndrome because they have a very specific physiology in mind. And the contrast guys don't do that. They include all cases of AKI after contrast, which is absurd, right? Because sick patients get contrast, right? They don't get contrast for no reason, right? And so what you have is this undifferentiated pool of AKI that's called contrast-associated nephropathy, and it's not. It's contrast proximate AKI. It just happens to be AKI right around the time they got contrast.
Yeah, this fits well with what I've encountered in the hospital when I've spoken about some of the literature around contrast-associated nephropathy with like other residents and other doctors. And, some of them are aware of all of the change in the literature, but, a lot of them also still say like, I've seen this. I sent the patient to the CT scan and then it came back and they, then the next day their creatinine was higher and they're not willing to doubt their own eyes when it comes to this subject.
Which is why that definition was so seductive, right? And I don't think it was an intentional disinformation policy, but what it did is we have this, this what's it called? Confirmation bias. I've seen it so many times that it must be true. But what you've actually just seen is that AKI proximate to this. There was an interesting study where a group of radiologists retrospectively went through patients that were in the hospital that never got contrast. And they said, well, how many of those patients fit the definition for contrast-associated nephropathy? You have a 25% bump in creatinine from, we'll put an arbitrary start date. It was like 17%, right? Because why? Because hospitalized patients are unstable. Their creatinines go up and down, right? And so they'll cross this 25% threshold. And the important thing is it goes up and then it comes back down. But the fact that it comes back down the next day doesn't take them out of the contrast-associated nephropathy pool. They're still included as anytime they cross that threshold, now it's contrast-associated nephropathy. And the thing that you really want to focus on when patients say that, when doctors say that is, well, what was the outcome afterwards? And, the interesting, take a look at, if you spend time looking at the contrast nephropathy literature, they will usually report deaths and need for dialysis. And the need for dialysis is so incredibly rare. And I think it's incredibly rare because this is wandering creatinine that happens to get caught by a very sensitive definition.
Just to clarify, you mentioned patients that have a GFR of greater than 30. In your mind, they can get contrast. Under what circumstances should you or should you not give venous contrast to a patient with a GFR less than 30?
So if you don't need to give venous contrast, I would recommend not giving venous contrast. Right? I don't want to sound smart. I don't want to sound obnoxious, but if you're looking for an abscess and this patient's going to die of their infection, give them the venous contrast, right? Like, is there a risk of AKI? Yeah, but there's a risk of AKI from sepsis, right? Don't let this patient wander around without a diagnosis, which sometimes happens, right? Like, oh, we can't give this patient contrast, so we don't know what's going on. I'm like, I think that's pretty harmful to the patient too. And I think the real question is, do I need contrast to make this diagnosis? And is making the diagnosis going to help the patient, right? If the patient's on hospice, okay, maybe we don't give the contrast there either, right? But if the patient needs the contrast to make the diagnosis, give the contrast.
Yeah, and one of your, or maybe a few of your lectures, you've mentioned drawing a parallel with vancomycin. Like if a patient possibly has staph, you give the vancomycin even if they have a low GFR, because you're concerned about the staph infection and you'll deal with the kidney thing afterwards.
Yeah. And I'll tell you, the real difference here is it's cost-benefit analysis. And it's very easy and direct to see the benefit of vancomycin versus the cost of AKI, because it's a therapy versus a cost. People are much more reticent to accept risk when the procedure is diagnostic, not therapeutic. And I think that this is really what we're running into. That's the difference between vancomycin and contrast. Contrast is not therapeutic, right? Except for barium contrast for intussusception, right? Outside of that case, your contrast is just a diagnostic. And then you're like, well, what am I going to do then? Well, that's another question. You're going to have to come up with a solution to how they're going to get treated. And right. And again, if there is no difference between the diagnosis, if the treatment doesn't change whether you find it or not, okay, well, then probably the contrast is not worth it. But if it's going to change your management, then you need to make the diagnosis.
In the arbiter of all medical truths official source, the website Uptodate, they recommend giving IV isotonic saline for hypo and euvolemic patients with reduced kidney function as a preventative measure prior to them receiving contrast. They don't give dosing or durations or injection rates for how it should be administered. What are your thoughts on preventatively giving fluids to patients with low?
Okay, so important thing is the low GFR. So don't mess around with doing it with CKD stage 3. People with GFRs greater than 30, the risk of contrast nephropathy is so low that you're going to cause more harm than good. Okay, and honestly, the data on the IV fluids is it's the best we've got, and it's generally accepted. And I do it if they have stage 4 or 5. And you just want, again, and I think what Uptodate says about the heart failure is super important. One of the biggest risk factors for contrast nephropathy is pre-existing heart failure, or so getting patients to have decompensated heart failure is not a good strategy. You want to prevent that or avoid that if you're going to then give them contrast. And so the dose is going to be 1 cc per kilo per hour. And the recommendation is, I think it's 6 to 8 hours before and 6 to 8 hours afterwards. That's the American College of Radiology National Kidney Foundation recommendations. And that's there was the first study that looked at IV fluids was a guy named Saline. A guy named Solomon, not Saline. His name was Solomon, not Saline.
And that was quite a coincidence if his name
right,
was Saline.
amazing stuff. And that was half normal saline. And then I want to say Marin was the guy who did half normal versus normal saline, and normal saline won. And then, but the interesting thing is then there's been saline versus placebo for people in that CKD stage 3 group, and there was no difference there. So in that low risk patients, you don't need the reason the NKF and the American College of Radiology say you don't need to do it beforehand is there's a randomized controlled trial that says you don't need to do it, right? They didn't just pull that out of the air. They were like, yeah, it doesn't make a difference. The incidence of this outcome is very low in this population. So, and you particularly said venous contrast, which is considered to be much more safe than the arterial contrast.
Yeah, can you talk about the difference between venous and arterial contrast in terms of the risk of AKI?
Yeah, I mean, again, the patient populations are different, but if you look at cardiac caths, the risk of AKI is definitely greater. But this is a more here now. We're not talking just about. Sometimes it's a diagnostic procedure, but sometimes it's a therapeutic procedure. Now we're going to go in and going to put it in a stent. And I think this is also a super important way to think is that a lot of this fear of contrast has resulted in patients that have kidney disease really getting insufficient care, right? People that have strong indications to go for cardiac cath because they got a ST elevation MI. If they have chronic kidney disease, they're less likely to go to cath. And that's BS, right? That we shouldn't be doing that to patients, right? We should be giving the best care possible, the evidence-based care possible, if regardless of what their kidney function is. We shouldn't treat these patients poorly. And that's what happens. And it's doubly bad because if you take a look at the population of patients that have kidney disease, it's a patient that's already, it's a group of people that already are getting, that are already harmed by society. It's people of low socioeconomic class, more likely to be Black and Hispanic and American Indian. So it's not a great look that we're under treating this population with strong indications to get a cardiac cath. And there's even a tag name for it. They call it renalism. It's supposed to sound like sexism or racism. Renalism, for systematic undertreating of people with kidney disease. But yeah, so the arterial, there's a lot of arterial data on contrast. It's funny, a lot of that data is also getting lighter. Like the toxicity of that is we're seeing less of that. The cardiac cath, we talked about some of the advances for venous contrast, but we've seen parallel advances for arterial contrast. Cardiac cath tables used to have a single plane fluoroscopy. Now they have multiple planes, so they get 2 views with every shot of contrast, and they can really start to build a view of what that vessel looks like. They're using smaller catheters, so each squirt of contrast is a lower dose of contrast. Interesting, there's been a couple of devices and innovations that have allowed lower doses of contrast, and usually to get approved, they have to go through a randomized trial. And when they go through these trials, they don't show any reduction in contrast nephropathy, right? The whole goal is to give less contrast to be safer. And they are successful at giving less contrast, but they don't show a reduction in contrast nephropathy. Sometimes you kind of wonder if the reduction was enough, 25% reduction in contrast, maybe that's enough, not enough for the threshold. But there was a randomized trial of intravascular ultrasound. So these are catheters that in addition to being able to squirt contrast, allow you to get a, actually I misspoke there. It is a catheter that allows to go into the vessel. It doesn't also squirt contrast, but it goes into the vessel and it gives you a ultrasound view, a cross-sectional view of that vessel. And you can kind of advance that and kind of look for plaque using ultrasound rather than contrast. Super cool technology. And this catheter kind of goes through a sheath. And so you can give contrast and then you can use intravascular ultrasound, and they do mixed modes of caths where they use both technologies simultaneously or in sequence. And when they do that, the contrast dose goes way down. And it's not hard to imagine why the contrast dose goes way down. You can find out exactly where you are with this ultrasound. You don't need to fine tune it with little bits of contrast. And so, this matrix randomized controlled trial, they dropped the contrast dose by 2/3. And there was still no difference in contrast nephropathy, right? You start to wonder, well, maybe it's not the contrast, right? And I start to wonder, is it not the contrast? There might be something, there's other things going on. I worry about cholesterol emboli syndrome. As we start to manipulate the aorta, we might be knocking off the fibrous caps of atheroma and causing cholesterol crystals to float downstream. And there's some interesting data that looks at the cholesterol burden above and below the renal arteries, where cholesterol burden above the renal arteries that can float into the kidneys is associated with procedure-associated AKI, while cholesterol burden below the renal arteries has no relationship to it, which begins to start to sound a little bit more like cholesterol emboli, a little less like contrast.
In terms of future studies going on, evaluating either arterial or venous contrast and AKI, is there anything that you're looking forward to coming out in the not too distant future?
Yeah, if there's big studies, I'm not aware of that. Our big trial was the PRESERVE trial. So at the turn of the century, there was a sequence of two really small trials that came out. One that showed N-acetylcysteine lowered AKI or contrast-associated nephropathy, and another one that showed that isotonic bicarb was better than saline at protecting the kidneys. And these were wildly underpowered trials. And the fact that they were positive was a miracle. And the fact that, and then they got published, one of them, the N-acetylcysteine got published in New England Journal of Medicine, and the isotonic bicarb got published in JAMA. And it was just like, these small underpowered trials get published in a high profile journal, and they flip a switch, and the standard of care changes overnight. It was amazing to watch, right? And it was exciting. It was exciting, oh my God, we have this new technique to really protect the kidneys from contrast. And remember, this is in the early turn of the century. This is the bad old days of contrast nephropathy with the old contrast agents, et cetera. And we were trying all kinds of things to prevent contrast. We were doing preventative continuous dialysis. You'd start the dialysis before they went to the cath lab. And then while they were on dialysis, they'd be getting the cardiac cath, to try to prevent this contrast nephropathy. That was a positive problem. But these tiny studies, I think one of them was 80 patients and the other one was 40 patients or 120 patients. They were tiny. And to finally disprove them, it took a randomized trial of 5,000 patients, right? It just was this massive effort to get it disproved. And I will tell you, it was the studies were incredibly well done. They were NIH-sponsored trials that definitively answered the questions that neither of these things helped. And we got a lot of side information from them, from additional studies and sub-studies that were part of it. It was a great use of the taxpayers' dollars to answer a super important question. And I think it answered it so fully. I feel that I wouldn't be happy. I wouldn't be excited to be a contrast nephropathy researcher at this point. I mean, I think what you're finding is the people that are really in the know here are like, there's not a lot of toxicity here. We've kind of solved this problem. There are probably bigger fish to fry.
All right, now we have a few rapid fire questions for you. What is your favorite segment of the Nephron and why?
Loop of Henle. No, let me change that. Cortical collecting duct. Cortical collecting duct is the aldo-sensitive part of the kidney, and it really is the brains of the operation, right? If you let's divide the kidney up, you got the glomerulus, that's a basket filter. It's just like a colander. And then you got the proximal tubule. I always call it big dumb reabsorption, where it's probably more complex than that, but just like the glomerulus leaks a lot of stuff, we need to cut down the volume before we can really fine tune it, so we'll reabsorb a lot of that. Loop of Henle is like the V8 engine. It powers both dilution and concentration. It seems weird that one part of the kidney would do both, but it does both, right? It dilutes the tubular fluid, and if you don't have ADH, just excrete that dilute fluid, and it generates the concentrated medullary interstitium. So in the presence of ADH, you're concentrating the fluid. But it doesn't make that decision. All it does is power it. And then the cortical collecting duct is where you fine tune the urine, make sure the right amount of sodium is being reabsorbed, right amount of potassium is being excreted, adjust the pH of the urine. That's the cool part.
Next question. What's your favorite electrolyte?
Sodium. Not even close. Come on. Sodium's the best. right? It confuses everybody. It's the reason we get tons of consults. And it even confuses me. Like it's a tough electrolyte, and we get all kinds of cool tools. Sometimes we use Lasix, and sometimes we use saline, and we use 3%, and we use tolvaptan, and we got all kinds of fun tools. We use urea now. It's the best. Lots of equations, tons of equations too, right? Electrolyte free water clearance is the best for sure.
What are 1 or 2 important papers in nephrology that more physicians outside of nephrology should be aware of?
Well, Craig Brader wrote a review article in the New England Journal of Medicine, and this is a deep cut. This is like 1998. But all it does is let's talk about the pharmacology of our thiazide and loop diuretics. And like everybody in the hospital's on loop diuretics. Everybody's on thiazides. And it's just basic pharmacology. And like, once you read that article, you're like, oh, I've been doing it wrong, right? You just get it, right? Like the idea that you dose, they give them metolazone. Make sure you give the metolazone 60 minutes before you give the Lasix, right? Which like makes sense if you don't understand that the half-life of this drug is 96 hours. And right, so giving it 60 minutes or 6 days before is not going to make any difference. This drug has such a slow onset of action. You should be giving a loading dose. You shouldn't be timing the dosing 60 minutes before. It makes no difference at all. And like, you just get that when you do it. And all of a sudden you're like, oh, wow, the bioavailability of Lasix sucks. Oh, maybe I should use more torsemide and bumetanide. Yeah, absolutely you should be. Those are much better drugs, right? And it's not rocket science, and it's something that we all need to know. So I like that. I like that one. One of the websites that I'm associated with is called NephJC, which is a Twitter nephrology journal club. We meet twice a month, and we just do a journal club on Twitter. And it sounds weird, but for whatever reason, Twitter is actually really good at being a medium for journal club. It's kind of the right length. Here's one. This is a good one. So there was a trial, New England Journal of Medicine, came out the end of last year. It's called the CLICK trial. And this is a study of using chlorthalidone in people with advanced kidney disease. GFR is less than 30. And so the dogma we're taught in medical school is thiazides don't work because your GFR gets low. And so you got to throw away the thiazides and pick up the loop diuretics as their GFR falls below 30. And this guy, Rajiv Agrawal, said, I don't know, chlorthalidone seems pretty strong in my near dialysis patients. I'm going to test it in a randomized controlled trial. And oh my God, chlorthalidone was super effective as a diuretic, is super effective as an antihypertensive. And right, how did he know it was good as a diuretic? Because he was having to treat hypokalemia and hyponatremia and all the consequences of the thiazides that we're aware of. If it wasn't working, they wouldn't be having those consequences. So it's a really nice randomized controlled trial. And he had to work really hard to get the study done. It was difficult to get funded. It took a long time for him to get it done, but it worked. And it really was, it's a game changer. Chlorthalidone in late stage CKD, the CLICK trial, New England Journal of Medicine.
We'll look those up.
Okay. And there's one last one. I got it. It's called the SAS trial. This is another New England Journal of Medicine article. And this was, so there's been a lot of debate of sodium and hypertension. And so there's been a number of studies that have tried to reduce sodium intake, and they were able to show that it reduced blood pressure. But the question was, well, does that really make a difference in terms of mortality? Are you just fixing a number, or are you actually moving the needle on fixing these patients? And the problem with doing that trial is having hard outcomes like stroke or heart attacks or heart failure. It takes a long time. It's hard to get people to reduce sodium. And so they randomized villages in China. And the villages got randomized to normal salt or salt that was where they took the normal salt and they replaced 25% of it with KCl, potassium chloride. And so they got both a 25% reduction in their sodium and a pretty significant bump in their potassium intake. And then they followed them for 3 years, and they had a significant reduction in both stroke and in total mortality. And so it really is kind of a really exciting trial, because it was a way to affect sodium intake in a creative and effective way, and it resulted in improved outcomes. SAS.
What does potassium chloride taste like?
supposed to be bitter. It's not supposed to be great, but mixed in with sodium chloride, it's supposed to be pretty good. You can buy 25% potassium chloride on Amazon, so you can taste it for yourself. Salt your fries with it.
Don't they kill people with potassium chloride?
Yeah, you got to watch the dose. That's correct. Got to watch the dose.
The dose makes the poison.
There you go. Paracelsus. Is that what it is? Paracelsus.
If you had unlimited funds for a single randomized controlled trial, what would you fund?
I think hemodialysis has kind of ossified without good randomized controlled trials. I think there are hundreds of questions in dialysis that have never been answered. And what I would create you know how they do A/B testing at Google, that every time you go to Google, it's slightly different because they're always A/B testing this, trying to find out which results and which aspects of Google are better. I would create that type of thing for dialysis. That if you are going to be part of you're going to be in this dialysis unit, we're going to pay you to be in this dialysis unit. You're going to be a subject, and every time you go to dialysis, you're going to get $100 or some amount of money, $100 a week to be a dialysis patient here. And people are like, oh, that sounds like a good deal. But as part of that, we're going to be A/B testing you constantly. And there are a million variables in dialysis that we do just because we do, and we don't know if they're better or worse, right? What's the optimal sodium concentration in dialysate? What's the optimum time on dialysis? What's the optimal magnesium? What's the optimal temperature of dialysis? All these things I just described have really compelling retrospective data that show that they make a difference for mortality, but no prospective data. And so I would create a culture of a culture of creativity. No, a culture of curiosity. That's the word I'm looking for. A culture of curiosity in my dialysis unit, and it would have to be a big one or a series of dialysis units because I want a big N, right? The whole point about A/B testing is you do the studies very quickly because you have so many people that do them. And so, if you take a look at the history of childhood leukemia, like we made rapid advances in childhood leukemia because every single kid got enrolled in a trial, right? If you got leukemia, you were part of a big trial group, and there was a question they were asking on every single kid. And that allowed us to move. And it's interesting, if you look at it, it wasn't like there was a single breakthrough that all of a sudden survival went from no thing to 50%. It was all incremental, bit by bit. They fought for every percent improved survival, and they brought it from 100% fatal for childhood ALL to 95% survival to the questions that we're now asking, because we're still enrolling every single kid, but the questions we're now asking is how much less chemotherapy can we give, right? We're giving less and less. That's the questions now. And that type of culture of curiosity would be, I think we could really optimize hemodialysis. I think there's many questions that could improve people's outcomes.
All right, last question. What are some important medical truths that very few of your nephrology colleagues agree with you on?
Phosphorus doesn't matter. We are constantly focused on hyperphosphatemia in dialysis, and I think it is a big red herring. We could throw vitamin D up there and PTH, and I think these things are all on the margin and not major. And I want to emphasize, this is out of the mainstream, and I don't want patients to other doctors to be treating patients based on this, but I have looked for the data. And the data is not, I don't think that the data is there. The data that is there, I don't find compelling. And I think we cause a lot of misery for our patients in terms of restricting their phosphorus intake, loading them up with phosbinder pills, and the data to support those treatments, especially given the amount of inconvenience they cause patients, is not worth the balance. Right? If we're going to do that to patients, if we're going to make them completely change their diet and take literally kilograms of medicine a year, because these medicines are 800 milligrams, 667 milligrams. Oh, take 4 of them 3 times a day. I mean, we're just loading them up with kilograms worth of this stuff. We better know that they work. We better know that they save lives. because they certainly cause a lot of adverse reactions. And so you can't be selling people adverse reactions without knowing that it helps them. And I'm not buying the retrospective data.
On that note, Joel, thank you so much for joining us on the External Medicine Podcast.
Excellent. You see how sweaty my pits are? You guys had me on the ropes. I was terrified. I'm a mess. It's like, if I was taking a lie detector test, I would be in jail. I'd be in the electric chair. It's just.
So for anyone who's listening right now, do you want to give a pitch for where people can find you on the internet?
Yeah, I'm at kidney_boy on Twitter. So at kidneyboy. And my blog is pbfluids.com. But you can just search Topf blog and it'll come up in Google.
Yeah, Mitch took forever to realize that was a reference to Dr. Strangelove. It was.
Have you guys seen the movie?
Of course,
yeah.
I went to film school. It was like one of my favorite movies for a while. Yeah.
Okay.
Yeah. Peter Sellers as Mandrake is like unbelievable, and that and I don't know who plays the general there, but that line is
General.
Probably my.
Yes.
What's his name again?
Jack Ripper. General Jack Ripper. Yeah. And that picture of Peter Sellers on the couch being incredibly uncomfortable while this guy raves like a lunatic about precious bodily fluids. That's what I feel like. I am General Jack Ripper talking about precious bodily fluids. And my medical students are Peter Sellers going, how can I get away from this lunatic?
That's a great movie. All right. Well, everyone should go check out PB Fluids. And thank you again, Joel. It was a pleasure meeting you and having you on the podcast.
Hey, thanks for the invitation. It's always an honor. Peace out.
Take care.
All right. Take care.